lateral side of the anterior tibialis tendon. I'm going to go to the base of the fifth metatarsal, come around, and find the navicular tuberosity. Then I am going to go underneath each of the malleus, or the malleoli, and then come back to the 0 point, okay? And I'm pulling a little tight, but I got 45.5.
Awesome.
Now you have a therapist and you're going to have a patient. So what I want you to do is rotate who's therapist and who's patient. If you're a patient first, you would go to the back of the line and then you become patient. Like if I'm patient, then I'm going to go to the back of the line and I'm going to be the therapist last. So everyone will have a chance to be patient, everyone will have a chance to be therapist.
Do you want one chair, not this group doing it and then that group doing it?
We could do it that way. I'm just worried about the noise and the ability for us to do this tug in the standard way, like protecting your client and things like that. So let's just do it one at a time, I would say. So if you were my therapist, okay, you would then tell your patient, sir, what I'd like you to do is stand up, and I'm going to time you to see how long it takes you to stand up, walk across that line, be sure to cross that line, turn around, come back, and walk and sit back down in this chair. I'm going to time you from the moment your rear end lifts up to the moment your rear end touches the chair. So it's butt up to butt down, basically. I'd like you to walk it as fast, but be safe. Walk it as fast as possible, but be safe. Okay? And so basically you would tell me those instructions, and then I would stand up, and patients will do this in clinic, and they'll, the moment their first trial of their butt coming up, that's when you start your timer. If it takes them 6 times to get up, it takes them 6 times to get up. So once they stand up, they walk, they cross this line, make sure that they cross, turn around. Their style of turning around is completely up to them. They could do this. Or they can do this.
Pivot.
See how both feet cross then? This foot crosses, and then they pivot, this foot crossed, and they come back around, and they can do it whatever way they want. And then they come and sit. So butt up to butt down, and that's when you would stop. Okay?
So with the patient who may lift their butt 6 times, which time do you start?
The first
The very first. So you get all
All
those
of
5.
them.
You get what up,
Let me put it this way. I've timed this before, and it's been 50 seconds of them just trying to get out of the chair. And it's, and it's fun, and they do this, and then they fall back down.
You can do it, come on.
Y'all are good?
We're good.
Okay.
Do we have to?
Of walking, and you want to be at full speed when you cross this line. So what you're going to do is start back there, and then someone, the therapist, will start the timer as soon as a foot crosses this table. And then you're going to walk with your patient, the timer's still going, and you're going to keep walking with them until one foot crosses this line. And so what you end up with is a known distance, which is 30 feet, and then you will know the time, right? So when you know the distance and you know the time, then you get a measure of speed. Right? Distance divided by time is speed. So I know the distance, I know the time, gives me a walking speed. This paper right here is to take their height, the person's individual height, convert it to meters because you have to do meters per second, and the statistical measure of dividing their meters per second, their speed, by their height kind of equalizes it. So that way someone 6'8" who can walk this in 10 seconds compared to someone 5'2" who takes 16 seconds, you kind of take their height and factor it out so that you end up with a static statistical measure. So that's the process here. So 7.5 inches or so. Picking up my shoe. Pick up my shoe, woman. That's her turning. So she's left to the left side. She's a little less. She's got some postural things going on with that as well. Turning in a circle. She had just recovered. Here's my favorite of all time. Listen to her feet hit.
Oh.
You weren't dedicated.
Oh, it gets better. Well, that's a high step, though, too.
So what did you give her for that grade anyway?
2, I think. I said, come on, woman, you gotta... Now listen to this.
Oh.
Y'all missed it.
What?
Dang it.
Does she curse?
They're like, sign up. I got a feeling if I do my grandfather, that's how it's going to be.
That's backwards. Would you rewind?
Marty, do
Yeah.
you have siblings?
Yeah.
Oh, they'll wipe them out.
What you doing?
Uh-oh.
Marty.
Because of that, we gotta start off.
Fast forward.
That didn't work out too
The AC's blowing good, man.
Where do you see?
The fridge note is flying. Well,
Oh,
she just
yeah.
stood up. So you couldn't-
You would recognize
good. That's the wind sheet.
How come we don't hear you giving her
Oh,
the...
that was purposeful.
You hear the whip. You hear the whip crack in a minute.
So 7.5 or so.
Look at the fridge thing.
You crack me up.
All right. When she does the step stool, everyone be quiet.
Okay.
Do we have sound? Yeah, we have sound.
I don't hear it.
Kelly, this video will be PG. I told her not to be so loud, and she starts off good.
Oh. She said that.
She said something. Just tell us.
She was really focusing on trying to do the best job she could, and when she knocked it over, she goes, "Shit." This is the tug, which y'all did out there, timed up and go.
You should make that chair hurt. That's probably the 11th time he made her do it. He's probably like, bye.
Fanatic. You get to see me when I had hair, I think, in this one.
Was it a mullet?
I'm gonna go see
It's just a little bit more carpet than what's here. So Tanetti is, can she sit statically still? Standing up and being perfectly still on
That house is haunted. You see that note moving?
You have no idea.
It's saying,
Now I'm looking at the distance between her 2 feet of one standing. I believe Tanetti says that should be less than, what, 4?
oh, there it is.
There's me. Bam! Look at him.
Oh.
Wow.
Now he's punching.
He's punching his mother.
You're out there and you punch your mom.
Stick and move.
Give him a chair. Your mother looks like she's having a blast.
That look she gives you.
She looks like a sign out here.
Oh, she cheated.
And I fussed at her.
Now,
Look, there she's mad at you.
happy now?
I think I'd say go again or something.
You have cue cards up or something?
No, I'm not talking to her. I don't want my voice on.
What was that?
Making room for lunch. That a boy.
That was the ghost.
Freaking bullfrogs in the house.
You did mention it was haunted, right?
Yeah.
Now, this one, let me go back and see if oh, this is good too. No, I don't think so. She didn't curse on. So we're looking at her sway. Her eyes were open a second ago, now they're closed. We're looking to see if she sways anymore. That tells you how visually dependent she is. If she stands perfectly still with her eyes open but with them closed, that tells you that she's using her eyesight to focus on something, and it gives her constant feedback. Now we're making her surface more compliant, which makes it more difficult. Notice her eyelids. This side had Bell's palsy, if any of you know what Bell's palsy is.
So you get a good balance.
This eye can't close on.
You jinxed her.
Watch this.
Forget that.
Marty, I'm not gonna lie, dude. With the red shirt and the black pants, you going to prom or something?
Homecoming, man. He had slack.
GARS
Gotta
M.
represent.
What does that mean?
This is a scale we'll talk about in just a second. I never use it, but I just want to expose you to it. The GARS M is basically a 10-foot walking distance, and you have to video it. That's the only way you can do the GARS M. You have to video it from the side, and you have to video it from the front. And what the GARS stands for is Gait Abnormality Rating Scale, modified. That's the M part. And what you're looking for is the quality of her step length. Does her foot clear consistently? And the grading scale is 100, 75, 50, 25 kind of percent. So if she's perfectly consistent with her foot placement and she's constantly clearing her feet, GARS would give her 100%. If she kind of trips occasionally, or if her footsteps aren't equal or they're varied somewhat, you score less. But because it requires video, because there's no way you could see that real time and protect your client, we hardly ever use it. Foursquare. I think, yeah. Wow.
Oh, she's a square dancer.
Checking her growth zone. I love the bear on the seat.
Oh, she has about 20 of those. All right, let me show you my wife's grandmother. Before we do that, though, you've seen her perform multiple data collections for balance. What sticks out to you? Anything.
I know people that spins
We know that.
One at a time? Yeah, single leg balance is certainly a struggle.
on the spin. She was unbalanced, I think.
She didn't spin in place. She kind of,
Witness her.
And then she had to kind of catch herself at the
and
end.
yeah, there was a little bit of that at the end of it.
And
So
then-
yeah, I can't argue with that. So maybe a little vestibular weakness. What else?
When she sits
And
down
then-
in the chair, it kind of looks uncontrolled on its knitting.
So what does that tell you?
She plops so weak.
Either
Um,
bad habits, like she knows the chair is there and she. But what is that? What worry do we have about that? Number one, there's no control. I think that's obvious. But what worries do you have if that's a technique she utilizes to sit?
That she'll fall.
Yeah, the chair could slide back. Yeah, spinal injury. Because she's female, she's elderly, osteoporosis, and she's hitting these hard wooden chairs, and all of that shock absorption goes right up the vertebral canal. And so she would be, someone who's at risk for spinal compression fractures if that were to continue, especially on lower height surfaces. That also tells you that there's a likelihood of quad and glute weakness as well. Because if she does that, she's obviously not using them. If she's not using those two muscle groups, they weaken. So those would be specific muscle tests that you would follow up with. In terms of her house, anything stick out to you about her house?
Bears on the couch.
Yeah, bear on the couch. What rug? In the bird, that's a table, I think.
No, further in the hallway.
Oh, this rug, yeah. There's a rug on the carpet.
Oh, that's carpet.
The edge of carpet right here, and the floor begins there. So there's a rug on the carpet.
That's
I have no
legit.
clue.
Is it
Interesting.
copper and,
Nothing.
That's her decoration.
Yeah, exactly. It's loose. There's no adherence to that carpet, so there's nothing to say that when you step on it, that rug won't slide out from under you. Look at this picture here and tell me what you see.
sharp edges on it.
Let's go ahead and actually do it.
There's a lot of stuff on the countertops.
Yeah.
A mysterious piece of paper.
What do you see on the floor?
It's shiny.
Yeah, she mopped that probably the day of.
Oh, the patterns?
The pattern. So what does that mean? How can that throw your balance off?
Does it affect your perception of space because everything looks?
Optical illusion.
It's like dots.
Think about the age of this person, and they're likely to have cataracts or macular degeneration. And these patterns that are very routine like that, if you have macular degeneration and the floor is distorted because of the changes in her vision, that can throw someone off. Look at the shadows too. That makes it look like the floor is multiple levels. I love that part.
Walks up, knocks his mom out cold, walks back.
She's thinking right now, I'm going to get you back. That's what she's thinking.
Here's her turn. And, there's a little bit of unsteadiness.
And the birds.
Now, she did better with it.
It was fun. I think she was just mad at you when she said the other time.
She was
I think it's this one.
to me punching her.
She gives you that look.
I gave her a look. And she's
At
like,
least she can look while she's
yeah, there you go.
There's a magical rug on the carpet.
Yeah, there's that look.
That's funny.
It's a new house. It's still settling.
It's the cat purr.
One more time. Look at her shoes. What advice do you give her about her shoes?
Buy some shoes with some good traction.
Yeah, the female variety of shoe is this patent leather a lot of times, and you can see your toes kind of are coming off of the side of them. They don't make female shoes the same way they make male shoes. The male shoe has got a much firmer leather typically, and the female shoe is a much smaller shoe because you know, like these shoes, resistance to the female wearing these big shoes that give them the amount of support they need because it makes their foot appear bigger. It's like those diabetic shoes that you see. They're really black and they're huge, and there's a cosmetic effect to them that you don't really want. Here's my wife's grandmother. God bless her soul. She's passed. Yeah. You'll really think I'm mean to her. That's fine. So think bird here. What are you assigning her for bird?
If you get it back to zero, we'll try.
Stand there for me for a second. Now this lady couldn't remember what she ate for breakfast, but she could quote Psalm 1 in its entirety.
Really?
She was amazing in that regard.
I like her.
Shoes partially untied. You know, you can see they don't go all the way to the top. When she stood, her feet are fairly close together, but just want you to see her walk. Notice the size of her footsteps. They're pretty small.
Does she have? Yeah, like doing that stuff. Should we be close to actually getting up just in case?
Oh yeah, if you were seeing this patient in a clinic, absolutely.
I'm saying when we actually do it, when you break, don't you want to have like the
Yes. Yeah, for the assignment, have a gate belt on.
Does she have signs of
Struggling
Parkinson's?
with that wire.
Yeah, look at that wire. That's high jump right there.
Is that to the video camera? You're an awful person.
I am.
You tried to.
What do you got against this woman?
Okay, come on back for me.
I mean, she's got an obstacle course to go through.
Where do you even fix a water floor outside?
That's part of what you assess.
Just walk back and sit down on the couch for me.
Just get up.
Yeah.
How old is she?
She's 93 in that.
Wow.
What? She has it that height because she doesn't need it for support. She needs it more for balance. So if it were lower, she would lean forward more. So that's why it's up high. If you need it for support, you need it low so that you have mechanical advantage. It can be higher if you just need it for something to stay. She reads the paper every morning and kind of... Yeah, she's going to kind of plop too.
I like her outdoor chair right there next to her.
And she'll tell you. I think at some point, yeah, listen to what she says right here. She's from Mississippi.
I thought you said cannonball. What did she say?
Call button that she wears.
Aren't you supposed to do the test on a hard chair, though? Because it's easier to get up from a hard chair?
This isn't necessarily a test.
Oh.
Remember the leading thing was IGDE. It's idiopathic gait disorder of the elderly. So this is more to see her movement. But when she moves, you could see components of her, and you could see components of her.
She giving you a stink eye.
Should we get a 1 or a 0? I mean, she's using her hands, but like it says, controls descent by using hands.
She didn't.
But yeah, but it wasn't controlled, so.
So now I'm testing her balance with her walker, and she should be stable on one leg with the use of her walker.
Can you try your other leg?
Show it all.
I'd probably give her a 1.
Doing wonderful.
Sits, but uncontrolled.
What was this video done, Marty?
I'd say at least 6 years ago, maybe. She's 100 this year, so she's
Wow.
7 years ago.
All right. Try and let go of your walker just barely. Like lift your hands up off your walker and try and stand on one leg that way. Put your hands right on top
And you did this without getting behind her?
Couch is behind.
Just plop
You're
on
such a
it.
loving son-in-law.
Someone had to make sure I capture the video.
Yeah.
That's why it's called a tripod stand, Marty.
When we video, can we use our phones? Or we need like a
Use
real
whatever
video
collects
camera?
video.
Oh.
I'm impartial as long as you can upload it.
Can
Okay.
it be a series of, oh, no, I guess you can't upload it.
That's fine.
You want us doing the whole process though, right? Talking and
Go ahead and turn in a circle. Yes, ma'am. Perfect.
Get my grandfather a get some bottle.
Stay right where you were though, don't walk away from your couch. Turn in place. Yes, ma'am, have to. Keep it with you.
This is going to take a while.
I love the things she's seen in her day.
Oh yeah.
That'd be remarkable.
She eloped with her husband.
Really?
Yeah, she was in love with her husband, and the dad said you can marry him, but you're too young. And so she and her would-be husband went off and eloped with each other.
Your
And,
legs hurt?
her husband was killed, murdered, actually in front of her.
Get ready to sit on the couch.
And my wife was in the middle seat when it happened too.
Where
She
were
was
they?
3. They were going to Orange, Texas, or coming back from Orange, Texas. He was a mechanic, and he owned a shop. And they went to Orange, Texas to get a piece of hydraulic equipment that raises and lowers cars. I guess it broke down. So they had a trailer in the back of their car, and a car came up behind them honking and flashing his lights. And the grandfather thought, oh, my equipment must be about to fall off the trailer. And before he could stop, put the car in park for any length of time, the guy behind him ran out of the car and fired a shot into the car. And fired down into the car, and the grandfather absorbed the bullet. But my wife was sitting right in the middle. She was 3. And then the person you see here was in the passenger seat.
He died right there.
Yeah, he died on the scene. Now this is a different lady. This particular lady was interesting. I'll tell you about her. She's 83 in this video and just as healthy as can be. Her name is Miss Doherty. She wouldn't mind me telling you that. She had just come back from England. When I met her, I worked at Baton Rouge General. She had come back from England on a red-eye flight, and she had tripped over her suitcase. She kind of got home, threw her suitcase, and went to bed, woke up in the night, tripped over her suitcase, and broke her kneecap. And so this is after home health and everything, and you basically can't tell anything's the matter with her. This is a furnace, underground type furnace, and if you stand on that, you'll start sweating. That's where her heat comes from, that heats that whole room.
Is it hot?
But there's a ledge there. What's
Is it
that?
hot?
Yeah, the metal. If you touch the metal, it was hot to touch. Look, Clayton, a cat.
Boom goes down.
Oh, wow.
Wait. Is it a real cat? Okay.
Oh.
So that sucker is stealthy.
It's about a pound.
Just waiting on Marty to take a couple steps forward.
Yeah.
Yeah, with that, I think it was her right knee that she broke. She's probably got a little bit of weakness still with that one. One shoulder higher than the other. It looks like her hips, her pelvis on one side is on the left as well.
Yeah, the cameraman's a little drunk too, maybe.
Yeah. And what's up with that light coming there, that line coming down? I don't know what this is right here. Oh, really? I have a funny story to tell you about her.
I bet you she was a firecracker.
Yeah.
I've had patients like her.
Oops.
She's got a little crow hop. Do it again.
But she didn't swing her right one.
the right foot.
Try leading with your other foot.
But she can do it. It's just her.
You led with your right foot last time, now lead with your left foot.
Could that be because of her height?
Yes, ma'am.
I don't know. I mean, she does fine.
You feel like
leading with her
I feel like the pillows are a little
She looks for that right for sport though.
Yeah.
She does better with leading with the right than
Yeah.
the other.
That cat's freaking me out. I think it's dead.
The cat and the cow. Cow right next to it.
Yeah, Snoopy, yeah.
That's a cat. Okay. Or a sheep or something. Change her. Yeah. Sorry.
And here's her stairwell. What do you notice about her stairwell?
Carpeted.
Steep. Wow, very shallow too.
What a trooper. Okay, I'm sorry if I ever have a room. As soon as you open the door, there's going to be a walkway from the door. I'm not just going to open up and start walking because knowing me in the middle of the night, I would tumble down it. There's going to be some flat ground.
Ready.
Proprioception for the shoulder. With the arm rest right here. Pinch right here. Stabilize in the back. You want your feet wide.
Cool. Okay. Thank you.
And it's going to be, in this position, it would be like the radius, so the radial styloid. And so again, before I get my measurements, I verify that I'm confident that I'm in that mid-axillary or mid-humeral line, like so. And then I verify that I'm along the radius, going to the radial styloid. This points to the radial styloid. This points to the greater tuberosity. Okay, if I know that I'm on those two axes, the fulcrum takes care of itself, and she's about 10 degrees of hyperextension. Okay, everyone okay with that? So if I were measuring this, I would say she's 10 to 0 to whatever this ends up being. Okay, this is her flexion. You don't want her to bend her wrist because the wrist coming into contact, if the fingers come into contact, may eliminate some. And this is going to align itself with the radial styloid. I again verify that my axes are lined up like they should be, and her flexion is 142 degrees. So if I were reporting her elbow flexion extension range of motion, it would be 14 to 0 to 142. So that's pretty straightforward in terms of elbow. Let's go ahead and do the wrist at this point. For the wrist, go ahead and sit. The best place to do the wrist is with her and sitting at the side of the mat. Thank you. Let's get a chair.
To whatever you're.
So it's not like elbow extension is this, elbow flexion is this. It's the arm that's what it was.
So like, in words, would you put
If you
Yeah.
for documenting your numbers?
Oh, no, I don't be
Would you
obnoxious
say-
about it.
there you gotta get it from
14 0,
Like,
but you wouldn't put like hyperextension.
No, because the 14 to 0 indicates hyperextension. She's got 0. So I'm not really concerned about documenting my 0 because I know that clearly she goes through that 0-degree range. So what I would do is I would come here and I would position this along the ulna, and this would correspond to the 5th metacarpal. Okay, and the fulcrum is going to be right there at the distal ulna, at the ulna styloid, sort of like right through the carpals themselves. Okay, so because I can't get even with her fulcrum, I'm going to elevate her some. Okay, put this so that I can get close. There you go. Now I can get even with her ulna, because before I couldn't do it. All right, so I'm confident that I'm right there. I'm going right to her lateral epicondyle. I'm on the ulna styloid, just distal to it. And then this one's along the 5th metacarpal. She needs to scoot out a little bit so this towel doesn't impact her range. And then I'm going to ask her to bend down, like flex her wrist. She needs to come out further because the
That towel is totally gaudy.
yeah, but that's not really stopping her though. All right, so there, I'm confident in all of my landmarks, and she is 95 degrees of wrist flexion. Okay, a little bit more than 90 degrees. Wrist extension's the exact opposite. I would put this along the ulna, still pointing at the lateral epicondyle, distal to the ulna styloid, 5th metacarpal. Don't worry about the finger, because her fingers can hyperextend, so you don't use her fingers, you use the metacarpal. And the wrist extension range of motion is 65 degrees. Okay, so that's wrist for wrist flexion extension. Deviation. The proximal arm is going to be the midpoint of her forearm, so it's like you're dividing the radius and ulna, the difference between the two. So here's my stable arm right along this. My fulcrum is going to be right there at like Lister's tubercle, right where the radius ends and the wrist begins, okay, like right there. And then my distal arm is going to be the 3rd metacarpal. So I place my goniometer here, get this lined up with, you can really use this knuckle. You can see that metacarpal knuckle really easily. You can line that up so that the line of your goniometer really cuts that knuckle in 2 equal halves. And let's have her ulnar deviate first. Okay, so you see how she left my mobile arm needs to move. And I'm going to put that right back on the knuckle again. And sure enough, I can see that it's right there on the 3rd metacarpal. So her range of motion for ulnar deviation is 30 degrees. And if I bring her this way into radial deviation, I put it back on the knuckle. Verify that again my axes are where they need to be. And for this one, she's at 25 degrees. So 30 and 25. That's it for uppers. We're not going to do the hand because OTs typically do the hand. And then to measure all the joints, we just will never have to do that. That would always be an OT patient. Does anyone have a pen? Another way you can do pronation and supination is to put this in your hand, and that's going to be your reference point for 0. You could do that. All right? For pronation, what you're going to do is your fulcrum is going to be right here on the dorsum of the wrist, like right at the radial styloid. Your stable arm is going to be here at 90 degrees. It can't be at 0 because then it pulls you away. To me, that's just a little bit more confusing. So I like 90 degrees for that. Whenever I do 90 degrees with this type, this kind of just sits right there for me. Okay. Now, as she pronates, what I'm going to do, this is my stable arm here. What I'm going to do is, as she pronates, I'm going to match this mobile arm with the orientation of that pin, so that
Clever.
I am parallel to that. So this is still parallel with the mat. This is parallel with the pin. I reestablish my fulcrum, which wouldn't really matter. And she is at 75 degrees, because I started at 90. And so I ended up all the way out here, so I had to do the math. 75 degrees. Yeah, exactly. So we come back up to that was radial. Radial style. All right, actually, you're right. It is ulnar styloid.
That's what this thing's saying.
Yeah. So if it were ulnar styloid, you would bring it down here. And then what you're doing is whenever she brings it across, your mobile arm is going to just rest right there on the dorsum of the wrist, right there on her radius and ulna.
If you know that you have to go parallel with the mat, parallel with the pin,
Doesn't matter.
why you have to start?
You don't.
Oh, okay.
What his question is do you have to start at the ulnar styloid? Can you do it at the radial styloid? And as long as you're parallel to the mat, or if you want to do vertical, you can do vertical. As long as you remain stable with your stable arm and have this match the pin, it doesn't really matter where your fulcrum is, whether it's ulnar styloid or radial. But your book will tell you this. It'll say to put this at your ulnar styloid. Sorry, I meant to say ulnar, but did radial. Put this on your ulnar styloid. You can have this be vertical, or you could have it be here, either way. Have it at your ulnar styloid, and then have her pronate. And what you're doing is you're putting this flat against the bones of the radius and ulna. See how it can't go any, you're putting it on both. So it's sitting on both the ulna and the radius. Orient this to vertical, and she's at, this time I got about 78 degrees or so, somewhere between 75 and 80, because this only goes by fives. Same thing if I'm having her supinate. I'm going to put it on this side now. I guess we have to do it like that. All right? Well, it's backwards. If she does like this, I'm going to do the same thing. I'm going to start straight up, and then I'm going to come across her radius and ulna like that, and I'm measuring that angle right there. And something I had forgotten to mention to you guys, because measuring the wrist isn't something that we have to do a whole lot, so it's probably my rustiest joint. No, I'm good. Whenever you measure this, this is your stable arm right here. It's the angle of the humerus. So for instance, if she's like this, and her humerus is way out here, look at how much she can pronate. Okay, that looks like 100 and whatever degrees. It's certainly over 90, right? And so ideally, you want to tuck in the humerus like this. But sometimes the mat doesn't let you do that, because look how high her shoulder is. You wouldn't choose to put your patient in that alignment. So if the place where you're measuring this doesn't allow you to tuck it in right by the side so that this is vertical, go ahead and bring it out. But now you have to compensate for the fact that your arm is out here. See how much I can pronate now compared to here? You see how it looks different? It's because my humerus is already, it's allowing me to do more. So just like you take away the extra, you do the same thing here. So your stable arm needs to match up with the humerus. Okay? And then go ahead and supinate for me. And so my stable arm is going to come matching up with her humerus. I'm kind of looking through. It's going to be parallel to the humerus. And this is going to be flush against there. And that's like 90 degrees. Okay, 0 to 90, I should say. Okay, for pronation, the same thing. If I put it here, I'm going to match my stable arm up with her humerus. And then I'm going to have her pronate. And her pronation, when I do it correctly this time, is actually less. But I need to verify that she's not going to be able to go further because of the mat. And her pronation is 75 degrees. That's about where it is.
So instead of doing it vertical, you would align it with a humerus.
And you see how I can pronate more when I'm out here than I'm here. And it's the humeral alignment. Someone tell me the landmarks for hip flexion.
Lateral midline of pelvis.
Okay. So draw a straight line along the lateral midline of the pelvis. That should also correspond to the midline of the axillary region as well. Since the axillary region, if you drew a straight line, would cut the mid-pelvis right in half as well. Distal landmark. Lateral midline of the femur and my fulcrum. Greater trochanter. So go ahead and put your foot down. All right, so we palpate each of these structures. I think fibula head makes a very good reference for the lateral midline of the femur, and then the mid-axillary line of the rib cage. You place your goniometer right over the greater trochanter, and you have him bend his leg up toward his chest by sliding his heel as far as it'll go, and then raising the heel up off of the bed and going all the way up as high as he can go. I verify that my distal arm and my stable arm are where I want them to be, and he gets a range of motion measurement of 110 degrees. Okay, everyone good with that? What would limit my hip flexion range of motion in this position?
Tightness in the back.
Tightness of the hip extensors specifically. Not hamstring.
Your glutes?
Active insufficiency.
Yeah, not active typically, because you're not going to have active insufficiency of your hip. Posterior tip? No, that's down.
I thought that tilt.
Tilt. Oh, okay. We would compensate for any tilt of the pelvis by changing the midline of the pelvis here, so that wouldn't affect us. All right. So if you're limited here, you would then assess your infield, and your choices are that you would have a soft tissue infield if he had an abdomen that came down to here, and you're pressing against his abdominal tissue, it would be soft tissue. It could be capsular if you don't have any sort of muscular influence, okay? Or it could be soft tissue infield related to muscular stretch, okay? That was for active. How far could he move it by himself? For passive, what I can do is when you're doing the hip, you might need a second person to help you, because the hip and the leg just weigh a whole lot, and you can't sometimes give the patient the support they need. Again, hold my goniometer like this with my thumb, and I can adjust it as I need to. I can use the back of my fingers to palpate for greater trochanter. I can put this there, and I can press on his knee. And what do you notice on his other leg right now?
It wants to come up.
So what's going on there?
It's good.
I hear compensate.
Tightness.
Can you agree? So his active and his passive, this active was 110, his passive was around 113 or 114. And so you would expect that to be equal in a normal joint. Now whenever I bent him up, this leg over here was rising. What do we say is the reason for that? Do you feel anything in that?
No, not at all.
Tight way.
Iliopsoas.
Not rectus femoris, because you've shortened the rectus femoris because the knee is extended. Let's slide off the edge of the table.
Oh,
This
this
is
is
something
the
called a
tailor.
Thomas test, where if we bend the knee to 90 degrees, and we, you don't have to keep it, we're going to look and see what happens. And I raise his hip up like this, and you see this hip start to rise, that's an indication of a tight hip flexor on this side. You can't differentiate, is it rectus femoris or is it the iliopsoas, until you have him straighten his leg and you see if the hip goes down flat. When he straightens his leg, both the weight of the leg and the fact that you've shortened the rectus femoris and given it more slack allows this hip to go flat. So go ahead and bend it down. And you see how he doesn't go to 90 degrees? That's a degree that you could measure theoretically. Someone else could hold his hip up and I could measure that knee flexion. And I would want it to be 90 degrees, but it's not. And so wouldn't you agree that that is a certain degree of tightness that I could measure?
Mm-hmm.
That where if I were stretching the rectus femoris, I'd put him back in this position, and because I've stretched him, he's gained range of motion of the knee. Because the rectus femoris has allowed that motion, I can get a before measurement and then an after measurement, and then I can document the improvement in that. Slide back up and get your belt. There's a lot of leg kicking going on over here, so I'm going to scoot this table this way. Kick away. All right, with hip extension, same fulcrum, same distal arm, same proximal arm or stable arm. Boy, someone's more nervous than Alright, so again I palpate for greater trochanter, put my fulcrum there, and I have him lift his leg up into hip extension. Now, when do I stop this range of motion? What am I looking for? Am I focused just right here?
When his hips rise from the table?
When his hips rise from his table, or when he increases his lumbar lordosis, then this is no longer hip extension. Okay? And so you want to verify that he's not lifting up his hip. Tell me if this hurts. Okay? By doing this, rotating his hips, can y'all see how that increases it? Nor do you want him to increase his lumbar lordosis. And so what you can do is quickly palpate. Go ahead and lift up. All right, stop right there. Hold it. Come here real quickly and grab your range of motion measurement, and it was 15 degrees. Okay, so you don't have to hold just here. You need to verify no compensations are existing. For a passive range of motion test for hip extension, you need a partner, someone who can help you, help stabilize the lumbar spine, lift. And he's going to have a lot more passive hyperextension than active typically. And then while I'm holding, someone would be getting the measurement, or I could try and do it myself. It's just a little awkward because I'm up here and my measurement tool is down there.
You got faith in you, Mark.
Thank you.
You can do it.
But again, not as accurate as if I were right in front of his hips. So I got 28 degrees that time. Okay.
Still didn't feel tighter.
What's that?
Still didn't feel like tighter or anything at all.
Came right on up. All right. Flip over to your back again. And a deduction. My stable arm landmark is what? ASIS. Flatten that down. So you palpate ASIS here, and then this is my fulcrum, this ASIS on this side. And then the distal arm will be the midline of the anterior aspect of his femur. So if I'm measuring abduction, I would have him scoot this way, because we need him to stay on the table the whole time. And so he's going to slide out. Now what am I looking for here? When do I stop the motion? When is it no longer abduction?
When he rotates,
Hip
when he
height and
laterally
rotates.
rotates his hip.
Felt a little something? Yeah, when his hip starts to rise, meaning his pelvis starts to tilt, then that's no longer hip abduction. And so what I want to do is have him go ahead and actively do it and stop right, go a little further, right there, okay? Right here his pelvis is still level, so that's where you would stop him, and then you would take your goniometer and his reading is what? It's on 60 degrees right now, but what's his degree of abduction?
60 minus, well, it starts at 90, so
Yeah.
90 minus 60, 30?
30 degrees. Okay, so you have to take into account that you didn't start at 0 on the goniometer. Make sure that you add those numbers correctly, because you could take your goniometer, read it, and see 60, and that would mess you up, because obviously 60 degrees would be somewhere out here, you know, so that's not accurate. All right, scoot toward me. Now, if I were doing a deduction, I would take this leg and get it out of the way. I would level out his pelvis again. All right, and now for a deduction, what he's doing is sliding his leg toward the other one. And what I'm looking for here is that he doesn't drop the pelvis down on this side. So whenever I see a pelvic tilt, I would stop him. And so I'll have him start again. Level out your pelvis. All right, go ahead. All right, stop. From that point on, he's starting to dip his pelvis down on this side. So his gluteus medius is causing a right lateral pelvic tilt. Place my goniometer here over the ASIS. Palpate this one. Bring it across. And his a deduction is 18 degrees. Taking 90, and he ended up at 108. So 90 minus 108 is 18.
108 minus 90. We got it.
All right. Any questions on the hip so far? Now let's go to internal and extrude all the way to the edge. And your knee has to be off. So in this position, you might need to pad his distal thigh so that it's not digging into the mat. So let's go ahead and do that. Another reason we would do that is we want his femur to be even. I want this to be a reproducible, thank you. I want this to be a reproducible measure. So we need to go a little higher, so we're going to double this up. Just hold it there. Just keep holding. There you go. Come down. All right. And we're satisfied with that. Let's verify. It's still a little down.
You want a little one?
Nah, I'm going to go another one here. Raise it up again. All right, down. All right. All right, I think that looks pretty good. We might have to stabilize this hip a little bit. All right, bend your knee. All right, what are my fulcrums for this measure? Or what are my landmarks that I'm using for this?
Perpendicular to the floor.
Really, it's the kneecap. It's the center of the kneecap. Because what I'm aiming for is to shoot straight through here, as if this were a bullet. It would go through his kneecap, straight into the mid-shaft of his femur. Don't worry, we won't do that. I left it out in the car and it's raining. My stable arm is either going to be vertical or it can be horizontal, whatever you prefer. Okay, my distal arm, get these next to all right, my distal arm is either going to be, the distal arm has to be along the mid shaft of his tibia. My proximal arm, it can either be horizontal to the mat, and I use the mat for reference. I could let it hang down, because this one right here, it'll find 0 degrees because it's loose enough. So I could let it hang down, or I can put them both up to here. Okay, so let's do it this way where both point up. All right, I find my fulcrum. I have him externally rotate. So which way? Everyone agree this is external rotation?
Yeah.
No, that's internal rotation.
Oh, is it?
Because of the hip, it was going in.
Okay, so this is external rotation. And if we have this oriented to vertical, straight up and down, we bring this along the mid shaft of his tibia, and his external rotation equals 43 degrees. We have him come back up to midline again, and we have him go into internal rotation. We need to make sure that the knee stays at 90 degrees. Put this again vertically. Bring this to the tibia. You can palpate for the crest of the tibia and know that you're on there. And internal rotation is 30 degrees. Okay, everyone good? All right, now I'll have him flip over into sitting. But this one, the one we just did, is a more passive. This one requires that he actively lift against gravity to both internally and externally rotate. And so we'll align ourselves with the femur for our fulcrum, for our stable arm, I'm sorry.
Isn't it the same thing where you're at 90 degrees of hip flexion? You know what I'm saying? Is it
Yeah,
the same?
I would elevate your leg up, so raise it.
That wouldn't work right there because it's doing the whole thing.
What's that?
You got to put it down towards his knee a little bit more.
Well, if it were any more, it'd be like pushing him. It's like right there at his popliteal. Now, if I made it fatter,
Yeah, that's what I'm talking about. Make it fatter. And
all right, raise up. All right, come down. You just need to verify that he's at 90 degrees.
what all looks better than.
Is there a certain time that you use the phone?
I'm just saying.
Prone is passive. This is going to be active. Okay, and sitting, you can orient point your goniometer so that you are vertically oriented. You know that he's got 0, so you can do it that way. So you're vertically oriented here. And he's going to come out this way for internal. So raise it. Now notice what he's doing. You've got to prevent any compensations anywhere. So don't raise that hip. Come out. And actively, this is my distal arm. This is my stable arm. I point my stable arm straight down. And he is at 18 degrees internal. Then for active, I would have him come in for external. My distal arm is this way. My stable arm's pointing straight down. And he is at 39 degrees of external. And so his active range of motion is less than his passive range. Questions on internal and external? Okay. Lie on your back. This time I will take this shoe off. If his calf is touching, you need to raise him up higher. So raise up again. You don't want the calf to prevent him from being able to fully extend. You want to determine if he has knee hyperextension. So I should be able to slide my hand under there. And I would tell him to relax his knee down. And you might see some of you where your knees actually go into 10 or so degrees of hyperextension. And you remember how we would document that, right? Be 10 to 0 to whatever. All right, so you get right here at the fulcrum, which is going to be his knee joint line. The distal arm is going to match his fibula. Lateral malleolus being a good distal landmark to see if your arm is pointing to the lateral malleolus, and then this would be the midline of the femur. All right, your proximal landmark to see if your femur arm is oriented correctly is going to be greater trochanter. Okay, I'm satisfied with this. And my distal arm is going to be pointing at the lateral malleolus. And push down for me. And when he pushes down, he actually has 0. Whenever he doesn't push down, he's lacking about 2 degrees of extension. If you have them. Everyone good with that? Another way you can do this is to have him being prone with his knee hanging off of the mat with some towels kind of buffering the thigh so that the muscle's not digging into the lateral aspect of the mat here. And so then you can have the effects of gravity, which is working to extend him by a prone hang. Let's show him a prone hang. Come down and let it hang. So you have to be here. Let me lower that. All right. You don't want anything under the kneecap, but this towel is just strictly for comfort. And now you can measure same landmarks. You can measure the way that the leg hangs according to gravity. So I'm going to palpate for greater trochanter again. I'm confident that this line points right to it. I'm going to orient this to the lateral malleolus. And in this position, he lacks, basically 2 or 3 degrees of knee extension as well. If he were to push down, now I'll have to compensate because he's raising up his femur. If he were to push down, I'd just re-verify. And that didn't really improve it any. He's still at 2 to 3 degrees short. Now there's not much of a difference. Like if you're arguing between 2 and 3 degrees, don't worry about that. I mean, this is 10 degrees short right here. And this is 9 degrees short. You can't really see the difference on your dial. Yeah, flexion range of motion would be 2 to whatever we're about to do. All right. All right, for knee flexion, he's in supine, and we're just going to ask him to slide his leg as far up as it'll go to where he can do it actively by himself. And then our landmarks are the same as they were for extension. We're palpating for greater trochanter, right there. And we're palpating for the midline of the fibula, right there. And his knee flexion range of motion is 140. Okay. Another way you can do knee flexion is on your belly. And if we did knee flexion this way, what are we looking for? What data piece are we collecting here?
Soft tissue.
No, it's not approximation because he's not gonna.
It's more of a hip flexion.
Yeah, it's more for what's his passive insufficiency of the rectus femoris, because he's going to be limited in this position because now his hip flexor is stretched out because the hip is straight, and now his hip flexor is being stretched out, specifically rectus femoris, because he's bending his knee. So go ahead and actively do that, and you just want to warn your patient you might get a cramp out of that. And we would measure knee flexion like this. Still midline of the fibula, still the midline of the femur pointing to the greater trochanter, and his range of motion in this position is about 135 or 136. So he doesn't have much passive insufficiency of his of his rectus femoris, but it did shorten his range of motion by some.
Doesn't that contradict what we found earlier?
You were 140.
Well, no, but whenever we did the hip flex, whenever we did the Thomas, does that show that I had hip flexor tightness?
Did we do the same leg?
No. No.
No.
You bent that
It
knee.
was my last one.
Mm-hmm.
Yeah. That's right.
Oh, yeah.
Never mind.
Any questions on knee? If I were testing his knee flexion here, I'm not getting any input from rectus femoris because I've got the hip inflection and the knee inflection. So his rectus femoris is being shortened over the hip joint, lengthened over the knee joint. So this is going to be more of an accurate measurement for what the knee itself can do, the joint itself, where if he flips over and does it, we can compare his amount of knee flexion here where the rectus femoris isn't playing a role to where the rectus femoris is playing a role, and the difference is the amount of rectus femoris tightness. And if that's significant, then that's something that you would need to treat to lengthen that. Because this right here, wouldn't we agree that the rectus, someone's ticklish, wouldn't we agree that the rectus femoris would limit the amount of pelvic mobility that you have? And so if you wanted to improve pelvic neutral positioning and pelvic stability, and every time he takes a step, the rectus femoris is pulling his hip down, and no wonder why your back is hurting is because with every step your pelvis is rocking back and forth. That's why you might address that. Any other questions about knees? It'll work the best. For ankle, you measure what motions of the ankle. What are you looking at in terms of ankle?
Flexor, dorsiflexion.
Anchor, plantar, and dorsey, and inversion, eversion. Okay. My landmarks for ankle plantar flexion are a little bit confusing in the sense that your axis, if you actually put this on the talocrural joint where dorsiflexion and plantar flexion occur, you're not going to be on your distal landmark, which is the fifth metatarsal. And so that can be a little hard to do or figure out. You can do it in this way, but what is the disadvantage of doing ankle dorsiflexion in supine? Gastroc, which is becoming passively insufficient. But that's a disadvantage if you want to see how the ankle moves by itself, right? But you can also see how the ankle moves taking into account that the gastroc might be passively insufficient. So this measurement is really a test of ankle dorsiflexion, taking into account that the gastroc length may compromise that. So let's go ahead and get that motion. My fulcrum is right through the lateral malleolus, because the lateral malleolus extends beyond the talocrural joint. My proximal arm is going to be the midline of the femur, pointing toward the fibula head. And I'm comfortable with that right there, so I'm going to hold it. My distal arm is going to be parallel to the fifth metatarsal. You see how this distal arm needs to be down here to be on the fifth metatarsal? But if I'm going to use my fulcrum in the talocrural joint, you can't do that. Okay, so raise up your ankle. And so I'm going to make this parallel to the fifth metatarsal, and his dorsiflexion range of motion is 12 degrees. Okay, so that's taking into account how well he can dorsiflex, overcoming any tightness that may be in his calf. To see how much dorsiflexion he has, taking the calf out of it, we'd put him in sit. So go ahead and do that. And so for sitting measurements of the ankle, I would have to be down here with him. Again, my landmarks are the same: fibula head, lateral malleolus. I'm comfortable with where this is pointing. And I ask him to dorsiflex. I make this parallel to the fifth metatarsal. And I'm satisfied with that, and that's about 20 degrees. Okay, so more dorsiflexion here than with his leg out straight. With plantar flexion, since he's here, I'd have him point his toes down. And plantar flexion is tricky because you have to orient this only to the metatarsal, because he can bend his toes down, and if you orient it to his toes down here, you're going to get more range of motion than what he's actually got.
Should the knee be at 90 for this, or does it matter?
I don't think it matters, because only for comfort, I would say, and reproducibility. I don't think your hip position and your knee position is really going to affect the ankle a whole lot. All right, so push down. I'm going to have this be horizontal or parallel to the metatarsal. And his plantar flexion range of motion is 50 degrees. Started at 90, ended up at 40. Okay, so 50 degrees. Okay, you can also test plantar flexion in supine. Just keep it the same. If you tested it that way in the beginning, you want to do it that way again. Take your sock off on this side. Inversion and eversion. What are my landmarks for that? Second ray. Why is it the second ray?
That's the middle of the foot.
Midline of the foot. And what's my proximal line? Okay. Tibial crest, pointing to the tibial tuberosity. And my fulcrum? Talocrural joint, or really subtalar joint for this. And so I go along the midline of his tibia. This is pointing straight to the tibial tuberosity. This is in the subtalar joint, pointing to the second metatarsal. I don't want to use the toes, because if I take the midline of his toe, you're taking into account more joints than just the one. So talocrural joint, second ray right there. And so I put my distal line like right there. He inverts his foot, and I just re-verify that that's on the second ray. I've re-verified that this is in the tibial crest, and it is. And his inversion is 45 degrees. All right. Yes, ma'am.
Is there a difference if they just invert or if they supinate at the same time?
Because I'm not measuring the fact that his foot may roll. I'm measuring just strictly the angle between his second ray and his tibia. So if, yeah, because inversion does involve supination. So that's going to happen naturally. Same position for eversion. Palpate the tibial crest. Verify that this points to the tibial tuberosity. That's right there at his subtalar joint. Align it to the second ray. And I ask him to evert. And his eversion is going to equal about 32, 34 degrees.
So would you say 30 or 35?
The meatus.
Ear hole, gotcha.
The ear hole. And then what are my other two landmarks? Because the fulcrum don't get you there very good.
Perpendicular to the floor, base of the mirrors.
All right, so perpendicular or parallel to the floor or base of the mirrors. If you do perpendicular to the floor, the advantage of that is you start, parallel, you would start at 0 degrees. Okay, so if you struggle with being able to, start at 90 and that messes you up, this would allow you to start at the 0 degree mark. This is parallel to the floor or the mat or, equal with the horizon, however you want to verbalize it. And this would be the center line right here is going to be right at the tip of his nose, like right there. Okay? That's my aiming point. I wasn't going to touch it, that's for sure. Oh. Right in the middle of a sneeze or something, and I got it. So what I'm going to do is I'm going to have him always start in good posture, because that affects the position and the range of motion of the neck. And I'm going to put this right through the middle of his ear hole. I'm going to line that up with the tip of his nose, and I'm going to verify that this is level with the horizon or flat. Okay, and then I'm going to have him go ahead and look down for me. And I'm going to put that at the tip of his nose again. Make sure that's over the external auditory meatus. And his range of motion is 34 degrees for cervical flexion. Now that looked like a lot of capital. That looked like a lot of capital flexion with a little bit of cervical flexion. So he should be able to go more than that. Bring your chin towards your chest. Go ahead.
I'm sorry I broke your gum.
So when you combine his cervical flexion with his capital flexion, he's at 60 degrees.
Do you want him to combine it at all times?
Well, you can do capital flexion by itself, but typically the functional measure for cervical flexion is the combined units of cervical flexion as far as you can go. Now, if you wanted to be specific and only get the cervical spine, what you can do is palpate C7, get off of C7 and go to T1. And when you feel T1 move, stop right there. That's where T1 starts to move right there. But he's got more capital flexion than that. Okay? And so you've got to make sure that he's maximizing his potential range of motion. But by palpating at T1, you certainly will feel it rise up like a flexion moment would. It separates those spinous processes. You can palpate for that, and as soon as you feel it rise, you stop right there. And then that would be his degree of cervical flexion. You can come and do this. And his cervical flexion, when you eliminate T1, is 45 degrees. Okay, normal cervical flexion is 50. That's what I believe that AAOS would tell you. But verify that number. Another thing I want to talk to you about is look how much the axis moves. Okay, I'm going to put this right over his axis at the start, and then go ahead and flex down. And his axis moves down probably 3 or 4 inches from the starting point. So, if you were following the axis, if you're setting it up and then intending to follow, you've got to follow that fulcrum as it goes down. We had discussed, I find it easier just to verify that he has 0, which obviously he does. He's got 0 degrees right there because he's going through it. And then if you know he's got 0, you could go ahead and just get the ending motion. But when you report that, you would report 0 to whatever that is, because you know he had 0. I wouldn't feel the need to say, oh, let's get in good, get right there, oh, a little bit, no, low, get there, okay, hold that, and then start at 0. I wouldn't feel the need to do that. You wouldn't have the position otherwise. What are your thoughts? know you differ. Go ahead.
I just think you need to make sure you verify they have zero.
Yeah.
And when you get to other joints like elbow and knee, if they have
Definitely.
hyperextension, then that's the case.
We did it for elbow and knee, but for the shoulder where you go completely through zero, we don't.
This is Marty in trouble.
So, good point. Make sure you do verify zero for elbow and knee, and we did that yesterday. Any questions so far? I put this horizontal, fulcrum through the meatus, this distal arm right through the tip of the nose, and then I'm going to have him look up as high as he can go. Okay, again, the fulcrum will move, so you have to adjust that. Re-verify that this is horizontal. Put that on the tip of his nose, and his extension is 52 degrees. Okay. For side bending, the fulcrum is what? C7. Okay, so I'm going to put the fulcrum right on C7. The staple arm can either point down, it could point up, I'm sorry. It could point down, or you can do it sideways, whatever way you want to go. What's my distal arm? Yeah, right through the middle of the back part of his head, so that you're splitting the back of his head directly in half. Half on the left, half on the right. So I'm going to choose to have mine point straight down. I wouldn't do it up, because then you have to separate the two, and that can be awkward. If you do it down, you can sort of line this up with the vertebral column, and so that makes a handy reference for you. Put the fulcrum right over C7. Put this right in the middle of his head, and that's my zero starting position. I would have him take his head in good posture and bring it to the side. And I'm just going to bring my distal arm such that it still separates the head directly into a left and right equal half. And so his side bending range of motion is 26 degrees. Then I would have him go to the left. I would bring my goniometer such that it divides his head into half. And he's got more side bending range of motion to the left than to the right at 42 degrees here. All right, did y'all see that? Side bend this way? Yeah. Look how limited he is to this side, and then look how much he's got over to here. Now when you do this, you've got to make sure this is
That's cool.
So you have to make sure that he's not compensating, because if I ask him to do this and he lacks, he's going to say, okay, I'm just going to bring up this shoulder and now I have more. But that's not pure side bending. So whenever he is side bending, palpate the shoulders to see if they rise. Now let's take that into the clinic. You see a difference here. Why? Tightens up
on one side,
upper traps, maybe scapulae. Okay.
Right-handed or left-handed?
Right-handed or left-handed?
Right-handed. What's that?
Do you carry a bag?
Do you sleep right side?
I'm trying to think maybe if
Yeah, I was watching you sleep last night. I think you sleep.
You just said you were watching.
Whoa, Jacob, when you watched me
definitely
sleep the other
sleep
night,
on
probably got ass.
We're not going there anymore.
Hey, he must have not watched us because he didn't realize we were freezing.
All right, let's not. His right side bending is less than his left side bending. What do I need to do now?
We want to stretch the right side.
How do you know?
Strengthen or stretch.
True.
Stretch
How do
first.
How do I know? Yeah, how do I figure it out?
Muscle testing.
Well, just test for the infields of it.
Test for infield. How do I
Oh,
test
go
for
Jacoby.
By doing passive range of motion, right? And by doing passive range of motion, I'm feeling a muscular infield. But I'm not feeling it necessarily in the traps. I'm more feeling it in a scalene. Do you?
Mm.
All right, I can
So tight
verify.
He'll get what he wants.
Verify if it's traps as well by exposing his traps to a stretch, kind of pulling that and shifting it from the side of his neck to more of the back. Because we know that the upper traps are a cervical extensor, right? Reversal. So I'm going to flex his head and bring it forward and side bend it, and that's going to be different than the feeling you had just a second ago. You agree? I said, do you agree? All right. Questions on that? I mean, he has a crick in his neck. You know, you've all slept on a pillow wrong, and I do this, and I go to pull it, and he starts to guard, you know, like activate, and he pulls back. That would be a spasmy type infeel, and that would indicate that the muscles are guarding against
Like
that
GTO?
motion. What's that?
GTO is guarding it? I just want to know.
I think the GTO, the Golgi tendon organs, would tell you that you're overstretching a muscle. This is like you go to move him, and these muscles are saying, ouch, you're hurting yourself over here, so I'm going to pull you back. That's what you could possibly feel. And the patient could tell you, if he bends over and he says, ooh, I get this pain right here, that's when you can start to find out, okay, you're limited. What are you feeling right now, Mr. Dugan?
Pain.
Okay, he just identified the problem. He clearly says that
Scalenes are tight.
He doesn't feel pain. Because whenever I'm doing this, I'm also
Or his
looking to
traps.
see what those facet joints are doing, right? And so when I side bend, the facet joints are gliding this way. If he had a restriction in one of those facets, I would expect it to hurt on this side. Because on this side, he's gapping those facets when he side bends. That typically doesn't result in pain, unless it's muscular. Because when you gap on this side, the muscles are being stretched along that spine. So he's complaining of a muscular stretch, so that's going to be part of our program for him. Lastly is rotation. Can you scoot? With rotation, if you're tall enough, you can kneel, but you may need to stand up. This is going to be my axis right here. The stable arm is going to be the imaginary line between the two acromion processes, and my distal arm is going to be this line going right through the bridge of his nose, through the tip of his nose, as if you're dividing the nose directly in half. So I'm not tall enough to see. I'm going to put the stable arm as if I'm dividing it right to this distal arm.
Stable arm acromion process.
Oh, there's no drama with that. Or you could have the patient sit in a chair. Alright, so I divide that acromion right in half. I put this right through the bridge of his nose. And then I would have him rotate to the right for me.
His whole body. Aww.
I'm going to bring that right through the acromion, like I had said. I'm going to bring this to where I'm cutting that nose right through here. Alright, and I'm going to say relax. And his range of motion was 84 degrees to the right. Then I would repeat to the left. Good posture.
This is distal arm or this is a distal arm?
The one with the numbers is always fixed.
Alright, relax.
Okay.
And range of motion to the left was 82 degrees. So let's go ahead and break up. It's a way of measuring cervical range of motion. It's called the CROM device. You have an inclinometer here, you have an inclinometer here, and an inclinometer on top. Now these inclinometers on the side and on the front, the needle is weighted by gravity, and so the needle will always point down. So what we do is we have the patient, if you needed to verify if she has 0, you can have her do this and do that. And you know she's got 0 because she passes through it. For cervical flexion, I'm going to palpate C7. Right there, I'm going to drop down to T1, and I'm going to feel that movement of T1 underneath my thumb. My instructions to my patient are go ahead and look down toward the floor as far as you can. Okay. Now tuck your head like as if you're bringing your chin to your chest. And her cervical flexion range of motion is 38 degrees.
That's awesome. That's what I need.
With cervical extension, it's the same thing, except I'm going to have her look up to the ceiling. And I'm looking for the motion that she has there, and it's 70 degrees. Okay? And she stops right when my thumb starts to whenever that T1 vertebrae starts to slide back with extension, we stop her at that moment. For side bending, she starts in a neutral alignment, and this needle should be pointing straight down at 0. And then I have her tilt her head by bringing her ear toward her shoulder. Now with this, you have to make sure that she doesn't compensate by twisting. You want her to bring her ear straight to her shoulder, but she was wanting to extend. Y'all see that? So we have to prevent that. Straight to her shoulder. Okay, and then we verified that she did that, and we grab a measurement, and that's 42 degrees. And then we have her side bend toward this shoulder, and we verify that she's done that, and she is at right at 38 degrees, so it's a little less. Sometimes those needles can stick.
What is top one's called?
Got to get that. This top one is rotation. Now you might be asking, what is this right here? Can someone tell me?
Magnets.
It's a magnet, and it's pointing to, each magnet has a pole, right? A north pole and a south pole, or a positive pole or a negative pole. Just like the Earth, the north pole is magnetized. So if I were to take this off and hold it here, the needle should point toward north, and it does. North is that way. Okay? We can use the Earth's magnetic pole for that, or we can use a very strong magnet to give us a definitive north, which would be directly that way, because the arrows are pointing.
Like, it doesn't? It looks like it's pointing towards
Alright, so the magnets are giving us a very strong pull of this needle, and it does like that when you put it on. So that's going to give us our 0 position. The magnet here the compass here on top has a rotating dial so that you can set 0 wherever the needle points. Okay? And so we put this back on her, and the needle orients itself to that way again. And I'm going to turn this dial so that the 0 is right in line with that red arrow. Now if I have her in good posture and she's in neutral alignment when I set her, and she is, we would have her turn toward the right. The needle is going to stay pointing straight that way, but now the dial is rotated, or the compass is rotated, and so she's got 54 degrees of rotation toward this way. And then I ask her to turn as far as she can. Make sure that she's oriented to horizontal. You don't want her to lift up or anything. And she's at 60 degrees this way. So this is the most accurate measurements for cervical range of motion. You just want to make sure that she's not twisting her shoulders, because that's going to equal more. So compensations still need to be looked at. But this is the best way of doing cervical range. We will come around and kind of work with each group with her as well. For cervical flexion, you have her in good posture, and you have a starting point and an ending point. My 0 is going to be right here on the tip of her chin, and I need to be in centimeters. And I have a beginning point right here, and I'm going to go to the sternal notch. And so I have enough tape behind me here so that I can put my thumb right there on the sternal notch. You feel how I'm right there on that ridge. Now that's my beginning measurement, and so that's going to be 13 centimeters exactly. Then I'm going to have her flex her neck down, and what she's doing is she's bringing the chin closer, combined, bringing the chin closer to that sternal notch. So go ahead and do that again. And then I'm going to put this right on the tip of her chin again, where it was a second ago. Put this on the sternal notch, and I subtract the two values from each other. So 4.2 centimeters from 13 is 8.8 centimeters worth of cervical flexion. For cervical extension, it's the same thing, except we know that her beginning point was 13. So I'm going to get this back lined up. Verify that it's 13. And it is 13 right there. And then I'm going to have her look up as far as she can. And it went from 13 to basically 18.9.
So 5.9.
So 5.9 centimeters worth of cervical extension. For side bending,
Mastoid.
so we palpate mastoid process, put our 0 right there, go to the tip of the acromion, and find an identifiable point. So the tip works really good because you can feel the tip really well, and you can feel the humeral head underneath it. Right? So tip of the acromion, that distance is, I'm using my thumbnail for my palpation, is 21.2. That's her beginning point, and then I'll have her tilt to the side, and this will be a shorter distance. I use my thumb to palpate mastoid process. And that reduced to 17.4. So from 21.2 to 17.4 side bending.
4.2.
21.2 to 17.4.
14.2.
Something like that. Whatever it is. You got it on video, so whatever that happens to be. For rotation,
Just 4.2.
yeah, I'm not a math.
No, I'm not good in my head though. I'm really not.
For rotation, we'll go tip of the chin to the lateral tip of the acromion process. Aren't y'all impressed I could just remember that? Yeah. I never do this in class. With all of these measures, I put my thumbnail right on the 0. I'm going to put this right in the middle of her chin as if I've cut her chin directly in half. And I'm going to go to the tip of the acromion process, and that is 26.1. That's her beginning mark, and then I'm going to have her rotate. I'm going to still put that right on the middle part of her chin, and I'm going to palpate for the acromion process. Put my thumbnail right on it, and that is 16.4. And so you would subtract the beginning from the end, and that's her rotation. This is difficult for me. I don't find it extremely reliable for clinical purposes because if I'm holding two ends of the tape, then I need someone else to verify that she's not compensated. And so to me, this is the least preferred method because I can set up a goniometer really quickly. I can palpate for a beginning and ending motion very easily. And tape measure is just a little bit more awkward. Clearly see how much you're flexing and extending. So for thoracolumbar spine, all you can test.
Hey guys,
y'all need
PG, right?
No, we're married. Oh, okay. We sit together.
The first lady.
All right. So all that you can do with goniometry is going to be side bending and rotation. So give me my landmarks. What are they?
Okay.
What's my fault?
C7.
True. It is the spine. That's one of them. Am I what? So S2, okay. And then what are my other ones?
The floor.
The floor, so the verticality of the goni would be pointing straight down to the floor. And what's my mobile arm?
Posterior aspect of spinous process of C7.
Okay, so I need him to stand up for me. And the reason why I need him to stand up is because this won't be on S2 and be on the mat at the same time. Not enough room. So I'm going to palpate S2. We know that if you palpate the iliac crest, you're at L4, L5. So if you draw a straight line out, you're right there in between L4 and L5. L5 would be right there. S1, and S2 right there. So here's my fulcrum right over my thumb. This is going to point down toward the floor. This is going to point at the spinous process of C7 right here. So I have him go ahead and side bend to the right. Okay, and what am I looking for in terms of stopping him? Whenever this side bending reaches the pelvis, right?
When the pelvis
flares out. Okay, so go ahead over. I'm going to bring this over to where it points right to C7. Okay, so you kind of have to draw this imaginary line. And I'm content that I am pointing right at C7, right there. Okay, so his side bending range of motion is 30 degrees. Okay, I reset, S2 right there, straight up, have this pointing straight down, and I have him side bend to the left. I bring this over to where it points right at C7. And
so it's parallel to your spine, though.
Yeah.
And pointing to C7,
yes.
correct?
And that is 29 degrees, so slightly more to the right than to the left. For rotation, I'd have him sit down, and I'd have him be at the front of the chair so that the back of the chair won't restrict his rotation. I need to be higher than him, so I'm going to grab a step stool. And my landmarks are going to be an imaginary...
No.
Hey, you want to handle your work? So my lines are going to be right through an imaginary line through the center of the iliac crest. Okay. So I'm going to have this come straight down. And I'm confident that that is there, and I'll come over here. And he is facing straight forward, and he is at 0 degrees, so that's going to be 0 degrees of rotation. As he turns, what I'm going to do is have this go through. I'm going to have... Okay, I'm not taking into account his head, so I'm still going to have this go through his iliac crest, and I'm having this point to the acromion process. That's going to be the rotation that occurs in the thoracolumbar spine. I'm not taking into account his nose or anything like that. So the cervical spine, he can do whatever he wants with it. I'm not taking that into account. But I'm going to stop right there through the middle of his acromion, and that's going to be my other measurement. Verify. And his degree of thoracolumbar rotation is 44 degrees. Do the same thing, but to the opposite side. Orient this right through the middle of his iliac crest. And then I have him rotate. I'm going to have this go through that acromion process right here. I'd need to be higher to verify. So let me grab this. And that's cutting his acromion right in half. I'm looking straight through that line. And I'm verifying that I'm at his iliac crest. And his range of motion is 34 degrees. I can palpate for S1. I could palpate S1. I'm here at the iliac crest. That's L4, L5. L5 right there. S1 right there. I can put my 0. No, S2 was below L5. Oh, S2, that's what I said, S2. I don't know why S2, if I want thoracolumbar, but I don't know, I'll go with it. We're shooting for S2 apparently. So L4, L5 right there, L5 right there, S1 right there, and then S2 right there. I put my 0 on S2, my ending mark on C7, and then I have him bend forward. He started at 52, and he ends at 64.9 centimeters. So from 52 to 64.9. His flexion and the gapping that occurred between his spinous processes when he flexed gave him an additional 12.9, I think 12.9 centimeters. Same thing with extension. Landmarks are exactly the same. You palpate for S2.
Why is it S2? Just because it's more stable?
I guess so. Maybe there is there's a tendency for S1 to be lumbarized, maybe. So maybe they include S1 for that reason. But S1 should be fused to S2.
Maybe it's for so you have a stable.
I guess so. Yeah, I'll take it. It's 7, and we're at 52. And then I have him extend. And you see how now those spinous processes becoming more approximated has put slack.
Like Bernie, yeah.
He ends up at 44.8.
How far are you supposed to extend that?
I've never used this as a means. I think it's just a comparison. So with Yoni or with anything?
Hold up, I'm coming. Okay, so we're doing supination. Supination. So she's got that ball at the bottom. Okay. Should be on the other. That thing. Am I seeing it? Yes. Okay, that. Okay. Middle finger.
73.7 centimeters. Then I would say, okay, sir, go ahead and take your hands and bring them and rest them along your leg there. And let's go not to the shoe. Come back up. Because that's the way he's going to do it, let's go along to the side of his leg. Still come to the front. All right. So I'm going to set this here. I'm going to come down to the side, like right in the instep, and I get a measurement of 72.4. So go ahead and bend down. I'm going to put my tape right there on that middle finger again, and I'm going to come down to here,
Get your leg straight.
and I'm going to get a measurement of 20.7.
What are they going to
Take the measurement at his tip of his middle finger, and you go all the way to the floor, and that measurement is 71.4. The repeat measure would be that you slide down, and you see how far that would be, and you see how far he slid. Okay.
I have more range of motion. Just because I had to keep my hand on my side.
All right. And that's 53.1. So you can compare the 72.1 to the 53.1, and that's 19 centimeters worth of slide. Your book talks about, though, you measuring how far he can get his fingertip from the floor. And while your book says that, I disagree with that as a really good method of deciding how far his range of motion is. Can someone tell me why that would be less preferable than just figuring out how far his hand slid down his leg? Well, you're using him both ways.
In the baseline.
You get hip hiking, whatever.
Hip hiking? But you can do that with either one.
Yeah, that's what I'm saying.
And so this will be a learning experience for you. What you'll notice when you look at the inclinometers, they have this blue liquid in it. And the blue liquid is a weighted liquid that weighs heavier than the water or the other substance that's in there. The water-like substance. And so the blue liquid's going to settle at the bottom. So no matter what position you put this in, the blue liquid would always go to the bottom. For the video purposes, see that blue liquid? It's at the bottom, and if I tilt it, it stays on the bottom. And so, what you can do is once you have your blue liquid and it's on the bottom, you can turn this dial to where you can put the 0 mark right there at the tip of where the blue liquid ends. And so the blue liquid ends right there. And just like with volumetric measurements, liquid's going to form like a trough, right? You're going to put this 0 mark right at the bottom of that trough.
Oh yeah, meniscus is the name of it.
It's a meniscus?
Yeah.
No, meniscus is this.
No, but you got one that makes it like a contact lens. It's the M off, but I think that's
right.
All right, both of y'all just have to leave.
We're just too smart.
You had to take chemistry several times.
I remember.
That explains why I failed chemistry and never returned.
Hold on, we gotta take chemistry to get into PT school.
All right.
Cool, man.
So here's how you use an inclinometer. Put that down. So. Hey, you were talking. You want to take off that shirt? So yes, sir. You want to throw it at Lana?
Question, what is that tattoo?
Where's Lana at?
I'm over here.
Sound like he was ready to fight. That's up, Jackson.
All right, turn around.
That's why he gets big bags.
He's a sponsor.
Go Tigers.
All right, so for the video, if I wanted to test cervical flexion, I would palpate T1, and I would put this on the top of his head, like right on the crown of his head. Now, that's going to be as long as he's in the 0 position. I can set this to where that water level is in the meniscus of the blue fluid, palpate T1, and then I could have him flex forward. And right there, I'd have him stop, and that is going to be 60 degrees. Now what happened is, come on up, what happened is it was in this position to start with, right at that 0, and as he bent forward, you see how that blue fluid moves away from the 0 mark, right? And so that 0 mark defines where he started, and the blue fluid went up to 60. For extension, what I could do is I'd palpate T2, the gap between T2 and T1. That way I can feel when T1 slides back onto T2. Put it in the same spot, set my 0.
This is easy to do.
Hey, don't be picking on the bald people. You gotta know
I would
stuff.
like that.
Yes. Bald
Come on back.
clients.
Stop. Right there. And that is 47 degrees.
Would you say that's more accurate than a goonie?
I'd say they're equal accuracy if you do it right. I need another one.
What's this
She
called?
walked over to me and she's like, she just walked in and I took off on top of the file.
Now, some clinics or some people would advocate using 2 of these. 2 reasons why I don't necessarily is I like to palpate when that movement occurs at the level that I don't like movement to occur. And you'll look at the positions of where they put their inclinometers, and to me it's a little bit less sensitive than my finger would be. For flexion, what they do is they put 1 here at C7. Now C7 is right there, and they kind of put this right there on top of C7, and they set it to 0. They put the other one on top of his head and set it to 0. Okay, so I've got both of these set to 0. And then I have him flex forward, and I don't have to tell him anything with this measurement, right? Because if he goes to 75 degrees here, and he's moved to 30 degrees here, I just subtract the 2 from each other, and you end up with 45 degrees. With me? So you subtract this inclinometer, what it reads, from that one, and you end up with 45.
But you don't like the 60 yet.
60? I thought it was 50. 60. Let's test
Right,
that
yeah,
again.
play back.
So we have 45 now.
Oh, yeah.
Go forward. Stop.
Oh, he's a stop at 45.
Yeah, 45.
That's good enough.
Come back up. Let's test it again.
He didn't specify.
Go forward, slowly. Stop. Yeah, I didn't do a good job that first time if I allowed him to go to 60, and he went faster. And so as soon as I feel this gap tension up, I know that T1's starting to rise. So I did a better job of stopping him this time.
So you need to make sure they go slow so you can.
Yeah, because if he's going fast, by
Yeah.
the time you stop him, he may have gone another 5 or 10 degrees. Moving this into this inclinometer. So the textbook talks about putting this right over the spine of the scapula, zeroing this out, and then putting this one on top of the head and zeroing that out. And then I have him move back. And with 2, you can just have him go as far as he wants. And he's gone 65 degrees here and about 5 degrees here, 7 degrees here. So you subtract those 2 from each other. Okay? So the advantage is you don't have to necessarily stop him. You can have him do whatever he wants, and you just subtract the 2. So there's an advantage there. But you take away any sort of palpation and control when you're having to hold these and your hands aren't in direct contact with the skin. If I were doing lumbar spine, only lumbar spine, where would I put this one?
On S2.
Not here on the iliac crest, S2. And if I only wanted lumbar spine, where would I put this one? T12. Because I want L1's motion. And so I would palpate, you know, S2, L5, or S1, L5 right there. You can use your landmarks. So L4, L5, L4 right there. L3, L2, and L1 right there. So I come here and I put this right there on top of T12. I put this on S2. Set them both to 0. Sorry, pushing. Have to get down at the level. And then I have him bend forward. And I don't really tell him to stop because I'm going to subtract these. This one says 84 right here. This one says 14, so 84 minus 14 gives you the amount of motion that happened between here and here. And we know that the majority, and then I could measure the difference between these 2 again, and you get a number that gives you the motion that occurred between here and here. But if I wanted to use 1, which is more practical because these are expensive and maybe each therapist has their own, I could put this on C7, palpate S2, have him go forward slowly and stop. Come back up. Go slower than that.
Bless you.
All right, stop. Right there is when S2 comes in. Go forward more. And then stop, and then you can get your measurement line. For cervical range of motion, the best way to set this accurately is with the C-ROM, cervical range of motion device. For goniometry, you can do pretty much any goniometric measurement in the cervical spine, and your response